Okay, we're going to be talking about some disturbed body image diagnoses related to pediatric care. We're on the Gordon's functional health pattern, self-perception, self-concept. Okay, so things we're going to talk about: cleft lip and a cleft palate, hydrocephalus, spina bifida, congenital hip, Duchenne muscular dystrophy, Down syndrome, intellectual disability, and the autism spectrum. Okay, first thing we're going to talk about, the hydrocephalus. So what is hydrocephalus? Just kind of break down what that word looks like. Hydro, water, ceph means like head, right? So this is going to be water like in the head or on the brain. Macrocephaly, so bigger head, caused by abnormal enlargement of cerebral ventricles and the skull as a result of increased intraventricular cerebral spinal fluid. And pressure. Overproduction, blockage of the outflow, or both can result in this. So cerebral spinal fluid should flow pretty freely from the spinal cord all the way down, and then certain ventricles in the brain, certain spaces that are in the brain. So if something happens to that flow where it gets blocked or obstructed, or maybe there's too much that's being produced, then we're going to have an increase in that fluid being trapped. And this is fluid being trapped in the brain. And then that increases what we call the intracranial pressure. This can be congenital or acquired, meaning like through trauma or some kind of genetic disease or something like that. And then we have two different types. We have communicating and non-communicating. So, oops, didn't mean to go that far. Non-communicating, this is an obstruction of the cerebral spinal fluid flow from the ventricles of the brain to the subarachnoid space. So that's 99% of the cases in children. Communicating means that the CSF is not obstructed in the ventricles, but inadequately absorbed into the subarachnoid space, which are tissues that surround like the spine and the brain. So it's just not adequately being absorbed. Okay, so here's a picture of, kind of a cartoon of, the spaces and then the flow of that cerebral spinal fluid accumulating. So in this picture, you could see baby's head is bigger. Fontanelles are bulging at this point. This is what would be an abnormal fontanelle. Baby's probably got a lot of issues going on here, but hydrocephalus, water on the brain. Causes could be developmental defects, myelomeningeal, which is going to be a type of spina bifida that we'll talk about, where part of the spinal cord has herniated, or an intrauterine infection, so an infection within the womb when mom was still pregnant with baby. In older children, it can be a complication of meningitis, a tumor, or hemorrhage, some kind of trauma and hemorrhage. How do we diagnose this? Well, we're going to do head circumference measurements, especially those newborns, right? And then CT, MRI to get a visual of what's going on within the brain. And then lumbar puncture, which is where they will take a sample of the cerebral spinal fluid from the lumbar spine, which is that lower spine. All right, so signs and symptoms, clinical manifestations of this. So head enlargement, you saw in that picture the head enlargement. And then the sutures, remember those are the spaces between the bones, they're going to widen, they're going to separate more. The head can be asymmetric and will increase in size. The fontanelles will be bulging at rest. Now it is normal for fontanelles to bulge a little bit when baby is crying, but if they're bulging while baby is at rest, that is a very ominous sign. Widening of the cranial sutures I just talked about, distended scalp veins, so that there's just more blood flowing to the head, vomiting from that increased intracranial pressure, irritability, behavior or personality changes, lethargy, so that's when baby is just laying there and not really doing a whole lot, and often very tired, can't get them to wake up, shrill cry. And then they may have a frontal headache, which is relieved with sitting up, right? Having gravity take some of that cerebral spinal fluid down. And then the headache can induce vomiting. Late signs, I'll talk about here in the next slide. Hey, late signs are going to be the setting sun sign or sunset eyes. So that's when the eyes are going to be looking down. Frontal enlargement of the head. So, their forehead is going to look like it's, getting bigger. Unequal pupillary response. So as you shine the light on one eye and that constricts, the other pupil responds slower or not at all. Increased blood pressure and decreased pulse. Those are all late signs of that increased intracranial pressure. Okay, signs and symptoms of increased intracranial pressure. We have what's called Cushing's triad. So what is Cushing's triad? Well, there's three things. You have to have an increased systolic blood pressure with widening pulse pressure, meaning the systolic is going to get really high, but the diastolic is going to stay kind of low. So then when you get the difference, that's the pulse pressure. Decreased pulse, so their pulse is actually going to drop, and then change in rate and pattern of the respirations. More so looking at that Cheyne-Stokes pattern. Other things we might look for: lethargy, irritability, vomiting, those bulging fontanelles at rest, and then we'll talk about posturing a little bit later on, but decorticate or decerebrate posturing, and then this can also result in death. Treatment management, surgery and insertion of a shunt to relieve the pressure of the fluid. So a shunt gets inserted into those ventricles to drain some of that fluid. Now they can just drain that fluid externally and get rid of it, or a more permanent solution is going to be letting it drain elsewhere in the body. We don't want to leave something, open to the possibility of contamination and infection to the outside world. So having this shunt that is within the body is better for a more permanent fix. So you can have ventriculoperitoneal shunt or ventriculocollateral shunt or an external shunt. So it just depends on where these shunts are going. So this first one, we often refer to it as the VP shunt, and I've got a picture of it coming up, and it's pretty common. So here's that picture of a VP shunt where it's, going into the brain and then draining into the abdomen. So VP it refers to which ventricle in the brain. So this is going to be the parietal lobe. Okay, peritoneal shunt. So it's going into the peritoneal cavity. Atrial shunt. So it's also going into a different cavity. Here's an external ventricular shunt. So this is what is draining into a bag outside of the body. Like I said, this is going to be temporary. We don't want this because it's just too much of a risk of contamination and infection. Post-op care. So we're going to be, after these shunts get placed, we're going to be measuring head circumference. We want to make sure that it's going down, right? If it's coming back up, then, that needs to be reported. We're going to be doing neuro checks very frequently, just making sure that, they did surgery on the brain. We want to make sure that they can still feel their hands, their feet, that they can move them. We're going to be checking those pupillary response. We're going to be making sure they can sense, dark or soft touch or sharp touch. And then position changes, we're going to make sure, we're repositioning every 2 hours per, you guys know this, per protocol. Oh, and that head circumference, we're going to be checking this every day or more often if needed. Avoid pressure on the site. Like, we don't want to disrupt that. We don't want to move it or anything. So we're going to avoid pressure on the site. Assess for increased cranial pressure. So what are those things that we're going to be looking for? We're going to be looking for Cushing's triad, which is that high systolic blood pressure with a widening pulse pressure, a low heart rate, and then a weird respiratory rate or pattern, not rate, but pattern to it. And then infection, we're worried about infection. So if we're looking at site, we're looking for redness, drainage, fever, that kind of thing. So assessing the drainage, cerebral spinal fluid, how they used to check for this is they would do what's called a coffee filter test. So, if somebody got was in a head injury and they've got this clear liquid coming from their nose and they wanted a quick way to see is this cerebral spinal fluid coming out their nose, they would do a coffee filter test. So they'd take a coffee filter, put some of the liquid on the center of it, and then if it formed rings as it was moving outward, then that would be a type of screening for cerebral spinal fluid. So we want to assess that drainage and see, is it cerebral spinal fluid? Is it infection? What do we got? And then the Glasgow Coma Scale. So the Glasgow Coma Scale, we talked a little bit about this last semester. So this is going to be a tool. You get points for, how alert you are, if you respond to pain, how your pupillary response is. There is a kids kind of policy to this. So just refer to your facility and which one they would like you to use. Awakens easily, limited responsiveness. So this is they're just tired all the time. There's not a whole lot to them. They do kind of look like they're going to come awake, but then they don't have that response that you're looking for. They're not answering questions. They're not reacting to food or something like that. Obtunded, this is limited interaction with environment when aroused. Stupor requires considerable stimulation to arouse, and then coma, vigorous stimulation produces no motor or verbal response. Okay, moving on to spina bifida. This is a neurotube defect. It's a congenital defect of the spinal cord in which there is a herniation of a part of the spinal cord. It can interfere with the meninges and cerebral spinal fluid through a congenital defect in the vertebral column. It's going to be mostly genetic. Can also be environmental influences as well as a nutrient deficiency of folic acid. We talked about that a lot last unit, how important folic acid is. Can be detected in utero by the alpha fetal protein test. They can also see this in ultrasound. Okay, so there's three main types of spina bifida. You have spina bifida occulta, which is it's going to be hidden. Occult, you kind of think of hidden, right? So a dimple can be seen with like a little tuft of hair at the base of the spinal cord. There is a failure of that vertebral arch to close there. That's what that kind of shows. It can be so small that it's only detectable by X-ray. They may have no signs or symptoms of this deformity. But, we want to be careful because there could be pressure on exposed nerve roots that are within, the body. Spina bifida, or the meningeocele here, the next one, we call that cystica. So this is going to be visual protrusion. So the meningeocele, this is going to be herniation of the meninges and cerebral spinal fluid, does not contain any CNS tissue or the spinal cord. Okay, this usually results in no paralysis, no neural elements, and not associated with neurologic defects, and occurs in varying degrees. The next one is going to be the myelomeningeocele. The myelomeningeocele, this contains meninges, cerebral spinal fluid, and the spinal cord. So this is going to be the worst of the three. It can cause some paralysis. It can vary in severity. You might have severe paralysis or minimal paralysis of the lower extremities. May have significant bowel and bladder control problems. Hydrocephalus is common with this. May have genital urinary defects and other ortho defects, and varying degrees of this. So I've got... So here's like a myelomeningeocele. You can see that the spinal cord has herniated through the skin. Okay, and then this is just a meningeocele where you can see the cerebral spinal fluid has herniated through the skin. Okay, here's another picture of an infant with spina bifida. The occulta, you can just see a little itty bitty dimple, and then this would be, we don't know, it could be a meningeocele or actually, my notes do say this is a myelomeningeocele, that the spinal cord is within there. So we want to keep them in a side laying or prone position with this. We do not want them to put any pressure on their back because that can put pressure on those nerves. I'm going to stop here with this recording and we'll continue on to part 2.